Hello, morning. Hello. My name's Ngozi Oluonye. I was just saying to James earlier on that my middle name is Margaret, but nobody ever calls me that. And I'm a consultant pediatrician in pediatric neurodisability. I work both at Great Ormond Street Hospital and at Moorfields Eye Hospital. So I'm really very privileged to be here and really grateful for Dave inviting me here. I've just had a quick look at your leaflet, and I'm taking a bunch with me. And the first paragraph actually struck me, and this was a quote from one of your members saying, "The fantastic joy of a newborn was just taken from us in one word, Aniridia." And that's what I work with parents and see children with a range of difficulties, visual impairment, more recently in the last 5 years. And so that really touched me. So my talk today is really a clinical exercise, clinical talk about what I do and how we can help. Most of the talk is based around sort of early development and touching a little bit on sort of young people, but I have to say not as much. This is the Developmental Vision team. We're part of the Wolfson Neurodisability Service, Wolfson Centre, based in Mecklenburgh Square in London, in central London. The Developmental Vision Service started there over 30 years ago by Tricia Songson, who was, you know Tricia? Yes. She is a retired now pediatrician who had an interest in the development of children with visual impairment because there was a gap in that knowledge. And so Tricia started the Developmental Vision Service. It was just herself and Joan Rennell, a speech and language therapist. And I trained under Tricia many years ago as a registrar, and I've since met her again, and always struck by her vision, and always struck by how she's still working very hard. So there we are, the old Wolfson Centre, which is beautiful and lovely, and then we were moved into Great Ormond Street Hospital, where our clinics are in the basement, if any of you have ever come. So there we are, we're subterranean in the basement. But the team has grown, and so we're a multidisciplinary team of pediatricians, myself, Jennifer Sargent, Elaine Clark, Alison Salt, who's since retired and who I really admire. We work very closely with clinical psychology. You might have heard of Naomi Dale, a few other psychologists, Jenny Slonim, Rebecca Greenaway. And we've also got occupational therapy as part of our service, and a speech and language therapist. So the team has grown since Tricia's days. This is a picture of the team at Moorfields. I work at Moorfields, as I said. This is our ocular genetics clinic team. It's a multidisciplinary team, probably one of the few, if maybe the only one of few in the UK, where we're led by an ophthalmologist, Maria Musiji, who is an ophthalmologist with an interest in clinical genetics. She's a researcher, as you know, a clinical scientist, and the clinic is run by Maria and myself as pediatrician. So she looks at the eye and I look at the child. And we've got nurses there with us, an optometrist, specialist optometrist, and we've got clinical photographer as well. And so it's a brand and family support as well within our team. Clinical genetics counselor as well. So we see a few children on a Friday, 3 or 4, sometimes maybe a bit more than that. Also run family clinics as well at Moorfields. So this is all new and we're learning. So when I was asked to speak today, I thought, well, I could talk about everything I know. Or should I just talk about the useful stuff? What's useful? And I hope what I'm going to say will be useful. But I thought, well, I just would talk about what I know as a pediatrician. So from my perspective, really, I am interested in the impact of visual impairment on a child's development and the impact of that visual impairment on visual development as well, how quickly that vision can develop if there is a difficulty there. I manage some of the medical difficulties that are associated with not just aniridia, but other conditions that affect the eye, because as systems develop, sometimes the eye is affected and other parts of the baby as well. But really, most importantly too, is getting that support available, because many of the families we see, once they've been given that diagnosis, just like this mum here, it all seems to be really gloom and doom. But there is help, and there is knowledge out there to move things on. So this is a little bit of science, the structure of the eye. We know it's a complex organ. So in some of the clinic letters, you may see things about the anterior chamber. So the anterior chamber is the portion of the eye that consists of the cornea, which is a covering structure at the front of the eye. There's fluid behind that space. And then you've got the iris, which is the colored part of the eye. It's a muscle, involuntary muscle, and then behind that is the lens. So that whole area is the anterior segment, and then behind that, the posterior segment of the eye is the bit between the lens, the retina, and the optic nerve. So with aniridia, we're looking at the anterior part of the eye. Now let's see if this works. Let's see, so this is a little video that Maria has put together.
How does the eye form? In the 3rd week of pregnancy, the eye grows out from the brain. The early eye has a stalk and a sphere. The sphere turns into the eyeball. The front of the eyeball remodels to form the cornea, lens, and iris. The back of the eyeball becomes the retina. It develops into several cell layers that can process light into chemical signals. The stalk becomes the optic nerve. This carries the chemical signals from the eye to the back of the brain, the visual cortex. Our brain then interprets these signals so we can see.
Thank you. That's nice. That's how I remember my anatomy. That's just so simple and so clear. So that's a little bit about how the eye forms, but really clear. So a little bit about inheritance, which you probably know a lot more about than I do, the sporadic inheritance. We know there are children who are born into a family where there's no history of aniridia. We call that sporadic aniridia. And then there is a familial inherited form from a parent or parents with aniridia. That's the autosomal dominant familial. So some children are born with an additional change in the genes that are adjacent to the PAX6 gene, which I know you know about. And that's the WTI gene, which provides instructions for making proteins necessary for the development of the kidneys and gonads. But the PAX6 gene, we know, is a gene that causes small changes in proteins that make up the DNA. And if you've got loss of function or no protein being formed, that will result in aniridia, which could be partial aniridia, or complete aniridia. We know that 30% of these changes are due to deletions in chromosome 11 on the short arm of chromosome 11. And the WTI gene is close to the PAX6 gene. And if there is a deletion that affects both genes, then you may have there might be a more systemic form of aniridia, where you have problems with the genitourinary system, with the ovaries as well. Some families may know about Wagner syndrome, which is an acronym for Wilms tumor aniridia growth problems as well. So aniridia, as you know, can be more complex than just involving the front of the eye. This is a diagram again, just showing us a little bit about, that's the cell, it's a nucleus where the DNA is formed. The DNA and the chromosomes are made up of lots of calls of protein, 3 billion base pairs. So we're very complex people, very complex microscopically and molecularly. And the DNA looks like a twisted ladder, and that's made up of smaller protein units, or amino acids they're called. So if there is a change in just one of those amino acids, you can get quite significant differences. So this is, I've just got some pictures here of partial or complete aniridia. Here the whole iris is absent, and in this other picture here we've got a partial absence of the iris. The iris is the lighter colored, but there is also a cataract there, which can form later on in life, not usually in childhood, but early cataracts can form. And this is just a diagram of the normal iris. So with aniridia, apart from the partial or complete absence of the iris, we know that the other parts at the back of the eye, the macula or the fovea, that's not as well developed, and that's one of the causes as well of the reduced vision and the nystagmus. And the complications of that include photophobia, so really a real problem with light, and a reduction in vision. So going on to, I really do pediatrics, thinking about the visual development in the first year of life, what visual skills does a child need to develop, and how are these skills useful for development? Those are probably just the two main questions when I'm seeing a child, that I'm thinking about what visual skills does this baby have, and how can we use what that baby has to move them on to the next step. So we know that normal vision develops quite rapidly in the first year of life, and the visual pathways continue to develop from the front of the eye right through to the back, up until 8 years of age. And as vision develops, interest in things, interest in people, interest in what things are also develops. So in the first 6 weeks of life, babies begin to develop eye contact and selective attention to target. So parents' face is close up, baby looks at that face and begins to have that understanding and interest, visual interest. By 4 months of age, vision continues to develop. They watch an adult 1.5 meters away and follow that adult with their eyes and with their head as they begin to understand a bit more about the world. They may also at 4 months develop what we call hand regard, where you've got a hand in front of the face, so they're beginning to understand, oh, I've got something here that moves, I've got this thing that moves their hand. And by 5 months old, they're beginning to reach out and bat at objects and beginning to understand what the world is about. By 6 months of age, they're beginning to shift attention from one face to the other, or from one face to a toy, and they're beginning to follow another person's direction of gaze. So what do parents want to know about vision? This is one of the things I hear sometimes when I see parents. They say, well, actually, I think my child can see more than light, but when we go to the eye clinic, they say fix and follows a light. But I think my child can see more than that. We sometimes hear the eye clinic and say, we won't know what your baby can see until we get more accurate measures, or we'll have to wait until he or she can tell us what they can see, or we'll have a clearer idea when they're older, which doesn't really help when you've got a little one. You really want to know what they can see so that you can help. And so using our knowledge of the development of vision, we would ask clear history from the parent about what do you actually think your child can see. And knowing what we would expect at 4 weeks, at 5 months, at 9 months, we can sort of work out where that child is. Because babies show us what they can see by the way in which they behave. We know that children and babies prefer, if looking at faces, they prefer a normally configured face versus a scrambled up one. And that's at 2 months of age. So quite early on, there is that beginning of discernment in babies with typically developing vision. We know babies have a preference for looking at parents' faces from as young as 2 days of age. So you can tell, and you can begin to, with an understanding of baby's development, begin to think about, well, what can my child see? And are they a little bit behind, a bit further behind, and what do I expect? So again, going back at 4 months, between birth to 4 months of age, babies can focus between 15 to 20 centimeters in front of them. Accommodation, that is the constriction of the iris and the lens, is more difficult, so vision is blurred, but they begin to learn to focus their eyes by looking at faces and then gradually moving it out to bright objects near them. And they tend to move their whole head to move their eyes, so we know that. By 2 to 3 months, they're following people, moving objects. By 4 months, their eyes are moving independently, so they're no longer squinting as much. And by 5 months of age, they're reaching out. So with normal vision or typically developing vision, you're learning about the world. You're beginning to learn about what things are and that things exist. You know where things are, what things are called, and that people look at things. So armed with this sort of knowledge about what we know babies know, we aim to see what measures could be developed to assess visual behaviors in children, taking into account what parents tell us about what they observe about their child. So we go through a structured process where we take a history of parental observations, assessing a child's visual awareness, aware, something's there, interest, something's there, and it looks interesting. And the aim of that is to develop visual attention through advice and promotion of vision. So your observations or parents' observations are really helpful. In a busy eye clinic, difficult to do that. Yes, you're in and out, you see 3 or 4 different people. A pediatric appointment be slightly different. That's when we really will dig down deep to find out what exactly what you think your baby can see. And considering at that stage to what is developmentally appropriate or if there are difficulties there. So we would do a structured history of vision function, and I have to say, because I work within a vision team, I know how to do this better than I did 10 years ago. Okay, so most pediatricians, and I've been a pediatrician for about, 29 years, I think, a long time, but have only really been working within the area of vision for the last 6 to 7 years. Won't really go through this history of vision function. So I think as parents, it's really important that you arm yourself with knowledge so that you are speaking from point of view of an expert about what your baby can do. So questions we'd ask is, does he or she look at faces, smile at a silent smile, because thinking back to normal development, babies smile, yes. Sometimes they smile at mom's voice, they smile because they're happy, smile because they're cuddled. But thinking visually, do they return a silent smile? That would be one question. And if they do, how close have you got to be? And have you got to do something else with it? And most of the times when we talk to babies, we talk and we smile. But again, this is one thing visually. If we take the hearing out of it, will they return a silent smile? Are they reaching out for objects, looking at small objects, or peering at objects or pictures? So we're thinking about visual interest as well. So this is Trisha, picture. It's an old picture from the Wilson. It's Trisha Songson, and this is what we do: follow mom and babies around the room. So looking at, is this baby following people moving around, moving towards an object? Do they recognize faces or objects at a distance? And sometimes you would see a baby who would look at a stranger's face, and you don't always get a smile. When it's mummy's face, countenance changes, and that tells me a lot as a pediatrician. So other people who assess vision do it really scientifically. The ophthalmologist, you get your eye examination, which is great. You get your near and distance vision check, color, intraocular pressure, looking at, again, at anterior segment. They look at the back of the eyes, and refraction, which is whether you need glasses or not. And then there are all the high-tech stuff as well for looking at the backs of the eyes to assess whether there is underdevelopment of the fovea. And then the electrodiagnostic test, the flashing lights looking for retinal function and visual cortex. Within our developmental service, we do this differently. So we are doing a functional measurement of vision. Now what you've got up on the slide there is our near detection scale that we use at the Wilson Center. And we're measuring very low levels of vision. So with a vision where you cannot get an acuity level. And at that stage, we're looking at, does the baby notice a glowing torch in a dim room? In a normally lit room, do they notice a light reflecting object? So there you go, that's our tinsel ball, 12.5 centimeters, or a mirror, reflected light from a mirror. In a normally lit room, can your baby see a 12 or be aware of a 12.5 centimeter high contrast ball? So we've got our yellow and black, you've got a high contrast. And the sizes go down from 12.5 to 6.25. It's about a tennis ball size. And if you look really carefully, I don't know if you can see it, it's a yellow cube, that's 2.5 centimeters. This is a yellow Smartie, that's 1.25 centimeters. That one there is a Hermesita, so it's a little sweetener. That's a 5 millimeter size object, 3 millimeter, and right there, very difficult to see, is a 1 millimeter 100,000. So this is our near detection scale. So really what we're doing is what can this child see at what distance? And again, we're thinking contrast. You can see our green background there. And so this is a child who in the eye clinic, they may say fixes and follows light. We can't get them to look at Cardiff cards, and we can't get them to look at anything else. But we know that functionally, we can work on what that child is able to see at a close distance. So we graded those into V1 to V4 levels. So with those targets, we have developed little programs. And with our distance vision, we will assess using everyday objects as well. At what distance can your child recognize a familiar, well, not unfamiliar, but everyday object, cup, brush, spoon, etc. At 2 meters, 1 meter, 2 meters, 3 meters. And we do the same with a range of pictures as well, simple to quite complex. We do have other acuity measures, and you would have seen these in the clinics used as well. So low vision can be improved from awareness to interest, establishing an understanding of that child's attention to active looking. So we know that vision development is not passive. It can be helped along by establishing an interest in what the child is looking at. And that's actually been demonstrated with RCT we did many years ago, looking at 58 babies with severe and profound visual impairment whose vision was actively promoted using our understanding of what that child's level of vision was, using the functional assessment. And at 12 months, there were two groups. At 12 months, there was a big difference between the two groups of children, those who were in the treatment group and those who were in the control groups. Developmental challenges, therefore, we know are present in children with visual impairment because children need to look and learn about people and things. We have to assess that child's play skills, mobility, and independence. And that starts with simple things like turning to sound, knowing where that sound is, what that sound means, and that sounds have substance. And we know language as well is also a difficulty in babies with visual impairment. So I think just wrapping things up here, thinking about the developmental challenges, as a parent, I wouldn't want any parent to feel that there isn't a way forward. There is always a way forward with the babies, always a way forward to think about the areas of vulnerability and to work on those areas. We know that there could be a wide variation in outcome. And there are some children who have transient, some have persistent delays. But with a good pediatric service and your VI teachers working with you in partnership, there is always a way forward. I think I need to end here. James is already in the background.
So we've got time for a couple of questions, but you're going to be around for the rest of the day.
I will,
aren't you?
yes.
So feel free to come and speak to her at any point. But if we've got any questions right now, we've got a microphone. So anyone want to ask a question now?
Hi, I'm Wendy Sainsbury and I head up the Family Support Services for Guide Dogs Children's Services. And I've known about, obviously, work with the team from the centre. Is it still that if for a parent that requires or wants a referral, they have to go via a paediatrician, or that they have to be, the child has to be a patient in Great Ormond Street, or can the GP referral? I know that it's not quite straightforward anymore as it used to be, but just wondered if you...
Yes, I can answer that question. At Great Ormond Street Hospital, because it is a tertiary national hospital, we can't unfortunately accept referrals from the GP, but we'd accept referrals from a paediatrician who may not have seen that child. At Moorfields, slightly different, and sometimes I say to parents, well, go to your GP, refer to me. I will see a child at Moorfields, referred through a GP, and then I can facilitate referrals into my own clinic at Great Ormond Street. It has to be done.
Yes, it's so key sometimes.
Yes.
To get to centres like yours.
Yes.
Thank you very much.
It's a pleasure.
It's a long time ago since my daughter diagnosed, and she's sitting next to me now. But what we were lucky we had a good VI person who helped. We didn't do any of the other things, but she did get me to do a lot more with Kate,
Yes.
with colour, with sound. But I just wondered, because Kate didn't walk until quite late. Is this a normal factor? And when she did walk, she took ages letting go. She'd hang on. She was 2.5, and she'd still hang on to my finger, sort of thing. Even though she could walk quite well. Now, I did understand that was probably, but it took a long time to walk. Is that a normal?
It is. It is quite normal, actually, and it's interesting, as you say that, we haven't actually got norms for motor development in children with VI. It's something I'm really interested in seeing, but it is not uncommon that a child with a visual impairment will take a bit longer, even though developmentally they are getting there.
Yeah, she was quite good, really, yes.
Yes, it's about object permanence and knowing that that floor is still there, and confidence as well, letting go and walking. So it's vitally important, I think, when you've got little ones, if you can get a physiotherapist involved, just to help you with transitional movements. So moving from your back, babies do a lot of their lying on their back and a lot of their best looking lying on their backs. But don't always roll and need that rolling facilitated. Tummy time, they hate it, but they've got to do it. But as parents, you need that support. And so I would say if your child is not known to the local child development team, insist that your GP refers you to a community pediatric service, physios and OTs who can help to move on to those transitional stages.
Yeah, the other one was sort of the VI teacher no longer exists where I am now. She's rather ashamed.
Such a shame.
You know, the post is not filled anymore. Isn't that terrible?
I think, yes.
I did find it in a rural area terribly good.
Absolutely. Health visitors haven't got this. They've got some skills, but they haven't got the specialist skills. There are resources online, the Developmental Journal, now for children with visual impairment, that is available on the e-learning. However, that actually is not available for parents, which is an issue. But they are, you can still get copies of the old Developmental
I actually
Journal.
have, that's a PDF, so
Yes.
people contact me, I've actually got that.
Yes. I don't know whether you've got, Lynn, the Show Me What My Friends Can See book.
No, I don't think I've got that. But I've got a whole range of the Department of Education documents that are a bit dated now, but still very relevant. So I've got the document that is for parents with children with VI and gives them lots of information. I've taken the early years framework and I've taken all the birth to 3, and I've looked at all the things that relate to vision impairment to give to your child in day nursery or preschool to help them. So we've got a whole range of stuff that if you contact me, I can let you have.
That's good. And if you did want, I've just got a slide there of the Show Me What My Friends Can See, Trisha's book. That's a lovely, easy to read book for parents and professionals. Put it in your handbag and just flip through it as you need it. Lovely line drawings. I should have brought one with me, but Lynn, if you do contact me, I can get some to you.
I just wanted to say that this was a step back in time, because 40 years ago James was for 5 years under Patricia an amazing lady, and our the 2 earliest memories for us was that I don't remember those things called a caterpillar that used to pull along and they used to make an awful noise, and we used to every day we'd have to sit James down and pull it along to get him to track it, and the other thing we had to do was to hold him face down and hurl him towards the floor for him to learn to put his hands out.
Yes, absolutely.
But actually for 5 years we were videoed, we would go, they would video us playing with him, and they would tell us what we were doing right and how we could do other things. And you know, I'm convinced that all that stuff we learned there, that we thought of being important at that stage, even though my background was early years, made James, I think it was amazing as he is, because from a very early age we knew the right things to do. And somewhere
you threw him at the floor. You threw him at the floor.
I knew when to duck.
You did know when to duck. But somewhere in your resources is probably videos of James. And certainly we made a video for you of him at home, so it's there somewhere. We never kept a copy for ourselves.
I will look. We do have all the videos going back many years.
Right.
Yes. Thank you.
Thank you very much.